Hello everyone. The next developmental disturbances affecting the structure of tooth, that is dentinogenesis imperfecta. In my last video, I discussed about amelogenesis imperfecta. Dentinogenesis imperfecta is also known as hereditary opalescent dentine and captedont teeth. So I will discuss in detail about dentinogenesis imperfecta. Dentinogenesis imperfecta is a hereditary developmental disturbance of the dentine in the absence of any systemic disorder. Similar dental changes may be seen in conjunction with the systemic hereditary disorder of bone, which is also known as osteogenesis imperfecta. Dentinogenesis imperfecta is an autosomal dominant condition affecting both deciduous dentition and permanent dentition. Affected teeth are grey to yellowish brown in color and have broad crowns with constriction of the cervical area resulting in a tulip shape. In dentinogenesis imperfecta, the gene maps to chromosome number 4 and it encodes a protein which is known as dentine sialophosphoprotein, that is DSPP. This protein constitutes about 50% of the non-collagenous component of dentine matrix. Then coming to classification of dentinogenesis imperfecta. Like amelogenesis imperfecta, the disorders of dentine also involve disagreements in classification. Two systems of classification are there, one by Whitaker and the other by Shields, are well accepted but not totally satisfactory. The first classification is Shields classification, that is dentinogenesis imperfecta 1, dentinogenesis imperfecta 2 and dentinogenesis imperfecta 3. By Whitaker, it is dentinogenesis imperfecta, second is hereditary opalescent teeth, and the third variety is Brandywine isolate. When coming to the clinical presentation of dentinogenesis imperfecta 1, that is osteogenesis imperfecta with opalescent teeth. Dentinogenesis imperfecta 2, that is isolated opalescent teeth. And dentinogenesis imperfecta 3 also show isolated opalescent teeth. Then discuss one by one. First is dentinogenesis imperfecta 1. It is without opalescent osteogenesis imperfecta with opalescent teeth. This corresponds to dentinogenesis imperfecta type 2 of Shields classification. It is caused by mutation in the DSPP gene, that is dentine sialophosphoprotein, which gene mapped to the locus 4q21.3. It encoding dentine sialophosphoprotein and dentine sialoprotein. The teeth are blue-grey or umber brown and opalescent. In the first clinical picture, you see the dentition exhibiting diffuse brownish discoloration and slight translucence. In the second picture, dentition exhibiting grayish discoloration with significant enamel loss and attrition. On dental radiograph, the teeth have bulbous crown, root that are narrower than normal, and pulp chambers and root canals are smaller than normal or completely obliterated. The enamel may split readily from the dentine when it is subjected to occlusal stress because it is so thin. In the radiograph, you see the dentition exhibiting bulbous crowns, early obliteration of the pulp. Then Salk et al. In 1976, they noted an increase in glycosaminoglycans in EDTA soluble dentine in the teeth from patients with dentinogenesis imperfecta. The next variety is dentinogenesis imperfecta 2, which is also known as Shields type 3 and Brandywine type dentinogenesis imperfecta. This disorder was found in the Brandywine triracial isolate in southern Maryland. The crowns of the deciduous and permanent teeth wear rapidly after eruption, and multiple pulp exposures may occur, and the dentine is amber color and smooth. Radiographs of the deciduous dentition show very large pulp chambers and root canals, at least during the first few years, although they may become reduced in size with age. The permanent teeth have pulpal space that are either smaller than normal or completely obliterated. Patients with Shields type 3 or Brandywine type do not have stigmata of osteogenesis imperfecta. Recent studies are consistent with the hypothesis that dentinogenesis imperfecta type 1 and dentinogenesis imperfecta type 2, they are allelic or the result of mutations in two tightly linked genes. McDougall in 1998, they provided information on the intervals separating four genes that map to this same region, all four of which are involved in dental development are DSPP, DMP1, IBSP and SPP1. In 1999, he stated that the manifestations of dentinogenesis imperfecta 2 can differ from dentinogenesis imperfecta 1 by the presence of multiple pulp exposures, normal non-mineralized pulp chambers and canals, and a general appearance of shell teeth. They also illustrated the amber discoloration of the teeth, adhesion and fractured enamel, as well as the classic shell teeth appearance on radiographs. Coming to histopathological features, the histologic appearance of the teeth in dentinogenesis imperfecta emphasizes the fact that this is purely a mesodermal disturbance. The appearance of the enamel is essentially normal except for its peculiar shade, which is actually a manifestation of the dentinal disturbance. The dentine, on the other hand, is composed of irregular tubules, often with large areas of uncalcified matrix. In the picture you see the dentine is irregular tubules with large area of uncalcified matrix. The tubules tend to be larger in diameter and thus less numerous than normal in a given volume of dentine. In the picture, the first picture, there is normal dentine showing regular dentinal tubules. In the second picture, there is large irregular dentinal tubules in dentinogenesis imperfecta. The pulp chamber is usually almost obliterated by the continued deposition of dentine. There is cellular inclusions, probably odontoblasts in the dentine are not uncommon. The odontoblasts have only limited ability to form well-organized dentinal matrix and they appear to degenerate readily, becoming entrapped in this matrix. In the histopathological picture, there is short misshapen tubules course through an atypical granular dentine matrix, which often demonstrates interglobular calcification. There is coronal dentine, which exhibiting short misshapen tubules within atypical granular dentinal matrix. Chemical analysis of dentinogenesis imperfecta. Chemical analysis explains many of the abnormal features of the teeth of dentinogenesis imperfecta. Their water content is greatly increased, as much as 60% above normal, while the inorganic content is less than that of the normal dentine. The density, X-ray absorption, and hardness of the dentine are also low. In fact, the micro hardness of the dentine is closely approximates that of cementum, thus explaining the rapid attrition of affected teeth. Then treatment for dentinogenesis imperfecta. The treatment of patient with dentinogenesis imperfecta is directed primarily towards the preventing the loss of enamel and subsequent loss of dentine through attrition. Cast metal crowns on the posterior teeth and jacket crowns on the anterior teeth have been used with considerable success. Caution must be also be exercised in the use of partial appliances which exert stress on the teeth because the roots are easily fractured. Full coverage crown in teeth with crowns and roots that exhibit close to a normal shape and size. Recently, composite combined with a dentin bonding agent in areas with occlusal wear. So these are all about dentinogenesis imperfecta. Please subscribe to my channel. I hope you like this video. Thank you so much.